I'm excited to be here to talk to you about motivational interviewing and health behavior change. The thing that I want to tell you before we start, motivational interviewing certainly consists of a set of skills and a set of processes and the like. But the thing that I want you to understand more than anything else is that motivational interviewing is a way of being with the patient. If you do not care about the patient, if you do not love the patient, and I use the word love in the agape sense, not the filial or eros sense, if you do not care for or love the patient, none of this stuff works. It then just becomes a whole bunch of techniques. If you've ever heard anybody try to be empathic who didn't really mean it, it comes across as very phony. And so motivational interviewing really requires that we care about the patient. Let me give you an example of something that I'm talking about. I was training 100 nurse case managers, and we had a question and answer session, and one nurse case manager said, look, I've got this 20-some-year-old asthma patient. He doesn't have drug coverage. He won't buy his drugs. His asthma's not under control, but somehow or other he's able to find enough money to buy his pack and a half of cigarettes every day. And I'm angry at him. And I looked at her and I said, okay, tell me why you're angry. And she said, well, I just told you, he's willing to spend money on his cigarettes, but he's not willing to spend money on his drugs. I said, I understood that part. I'm still asking you, tell me why you're angry. And she looked, and somebody else in the audience said, well, Bruce, you obviously don't practice. That's why you don't understand. And I smiled and I said, let me reframe this for you. Let me see if this makes sense. What this man is doing is tragic. Do all of you hear that? What he's doing is tragic. He's choosing something very unhealthy over something that might actually help him, both in terms of life expectancy and quality of life. Why would we be angry at him for choosing something tragic? Why don't we feel compassion? How many of you understand what I'm saying? Okay, this is what I mean, that if you don't care about your patient, why in the world would we ever expect that treating a patient with indifference or disdain would ever cause them to want to listen to what we have to say? Why would we think that being impatient with a patient and wanting to beat them over the head because they're not getting it right would cause them to want to go, gosh, you're right, sure, I'll do that. And so motivational interviewing is a way of being with the patient, and it's a way of being that requires caring. We have this tendency in healthcare to notice when the patient is doing what? Something wrong. They're not taking their medicine. They're not losing weight. They're not changing their diet. The point is, with motivational interviewing, it is more important, if not at least equally important, to notice not only changes in behavior, but changes in the way they're talking. If I do a lot of work in smoking cessation. If the last time I talked to this patient, he said, there is no way I'm quitting. And this time when he comes in, he said, I thought a little bit more about what you said about quitting. This is change talk. Does everybody hear it? Is he ready to quit? No. But do I need to notice this? And the answer is yes. I not only need to notice it, I need to explore it. I need to ask, tell me more about what's got you thinking about this. What's caused you to think more about it? And why would I want to talk to him and ask him to say it out loud? Because anytime we can ask a patient to say anything out loud, we get more of a commitment to change. So we don't want to just say great and say, when are you going to quit? We're going to say, tell me more about what's got you thinking about it. What would be the next big push? What would cause you to think even more about quitting? They're not ready to quit, so we don't start setting a quit date at this point. Or if the patient says, I've been thinking a little bit more about watching what I've been eating. Again, tell me more about that. What's got you thinking about it? And so we really have to, again, because it's a way of being, if we really care about the patient, we want to look for opportunities to praise the patient's not only behavior change, but change talk. And to notice it and let them know we've noticed. But this takes effort. It takes effort. We did a major literature review. We've got a research piece in a journal called the Journal of Advances in Therapy. The July-August issue has got a 40-some page review piece on what we've learned about treatment adherence. Here are some of the things that we found. Theory-based interventions. Motivational interviewing is a theory-based intervention. The trans-theoretical model change. How many of you have heard of Prochaska's work? readiness to change. We'll talk a little bit more about that in a while. If you notice on each of these categories, there's a huge range of the impact of these things on treatment adherence. And when you go into the literature, when you really mine down, you start finding out, well, why did some people get 43% improvement, which is pretty significant, versus 5%, which can be significant depending on the illness, but certainly not as dramatic as 43%. And some of the things that you find out when you look at these theory-based interventions is what you find in the research is that those practitioners that were using theory-based interventions or those practitioners that were willing to address ambivalence and resistance on the part of the patient, so that when the patient expressed ambivalence about doing the behavior, uncertainty, I'm not sure if I want to do this, I don't know if this drug really works, I don't know if I really believe I have osteoporosis. So if they expressed ambivalence or outright resistance, I don't want to quit smoking, I'm not interested in losing weight at this point. If the practitioner addressed it, explored it, the patient was 5 times as likely to be adherent. That's hugely significant. 5 times as likely. On the other hand, when we look at disease-based interventions, one of the interesting things we found out here is that in many cases, even though the patient did not take the medicine as prescribed, their illness still improved. And when you mine down, what you find, and this is important also to both pharmacists and other healthcare providers, particularly nurse case managers who are dealing holistically with patients also, is that what we find is that drug therapy alone is not enough. And that especially when you're dealing with diseases like high cholesterol, that if they're only taking the drug but not making changes in lifestyle, of course, effectiveness may not be where we want it. On the other hand, if they make the lifestyle changes, they may not end up needing to take the drug. We have got to stop compartmentalizing patients. Pharmacy has got to stop thinking that what we do is just drug therapy and ignoring lifestyle changes. Does that make sense to you? Because especially with Medicare Part D with MTMS, where pharmacists and other healthcare providers have an opportunity to be paid for outcomes, we can't just focus on drugs or just on lifestyle changes. Dosage simplification, you know, you would think that the theory was, and here's the thinking, if you go from 4 times a day to 3 times a day to 2 to 1 times a day, compliance should improve. And that's fundamentally what the literature says. On the other hand, using Procter & Gamble as an example, they've got a drug Actonel. You can take it once a day or once a week, and now GSK has got a drug that can be taken once a month. Well, the claim is that once a month would be even better than once a week. And the fact of the matter is, even if there was research to support that, which there's not, by the way, even if there was research to support that, the fact of the matter is at the individual patient level, you can throw all of that out. Because the fact of the matter is, one patient may really need to take the drug once a day in order to stay compliant. Another patient may only need to take it once a week, and another patient might be better off taking it once a month. And that's one of the things motivational interviewing teaches us. Reminders, go anywhere from 1 to 41%, and the key there is continuity. You can't just remind somebody once every 6 months and expect something to happen. Not significantly anyway. Discharge interventions, you would expect those to be a little bit higher, but what we find is part of the problem with discharge interventions is the way the patients talk to. Oftentimes they're given information and they're spoken to in terms that the patient may or may not understand, and if you think the patient generally is going to interrupt and say, I don't have any idea what you're talking about, it's not going to happen. And oftentimes we tell people simple things like twice a day. What does that mean? We know that it means approximately every 12 hours, but I'm busy. I'll take one at 8 a.m. and one at 10 a.m. and I'm done. Right? Or PC and HS, what does that mean? After meals and at bedtime. Well, how many of you eat 3 meals a day other than when you're at meetings like this? Do you know what I'm saying? And if you have diabetes, how many meals a day might you eat? 6 or 7, and then the patient takes it 8 times a day, and we go, no, you shouldn't be doing that, because we haven't been clear about what we mean. So these are reasons. One-time interventions don't, they work somewhat well, but a lot of it really depends on how we're talking to the patient. Self-care initiatives haven't been all that successful. So these are the kinds of things that we've gleaned from the